So in order to discuss about the new migraine treatment, we would like to know what exactly is a migraine. So migraine is defined as one-sided throbbing headaches which can last for 4 to 72 hours, and it can have two of the following characteristics: unilateral, one place or one side, but it can be bilateral, pulsating or throbbing quality. It can be moderate or severe pain in intensity, and can be aggravated by any physical activity. Along with this criteria, if the patient has photophobia or phonophobia or nausea or vomiting, then patient meets the criteria for migraine headaches. So if you look at the stats, there was a study has been published in American Academy of Neurology a year ago that any headaches which is lasting for more than 4 hours, statistically, most likely it will be migraine rather than any other headaches. The second largest common diagnosis in the population is tension type headaches. So what are the information we should know about the migraine before we start discussing about the treatment and mechanism? A typical migraine patients, if you look at the migraine patient, they will be complaining of headache, one side. They don't want to talk. They don't want to do anything during the whole day. They would like to remain in their room, dark room. They don't want to see the TV, and they might be nauseous and throwing up. And the critical thing is it should be reversible after 4 to 72 hours. I remember my mom used to have the headaches, and it was a headache day, and we never used to talk during that time, and I never understand that concept of migraine back home in Pakistan. But then when I was doing my residency, and the good nurses were waking me up in the middle of the night asking about the laxative and diarrhea about the patient, the next day when I was not able to sleep, I was having throbbing headache on one side, lights bothering, noise bothering, and a little bit nausea, but not much. And I was having the headaches. I used to take Tylenol, ibuprofen. If I take it early, my headaches were well controlled. And then ultimately, one of my chief resident told me that you have migraine and nothing else, and start working on your risk factors or triggers. So that's how we should see a patient. Any person who's having headaches in a dark room, most likely it's a migraine headaches. What is allodynia? Allodynia is defined as a painful sensation to a symptom which is very much normal symptom. For example, if I am having a migraine headaches, the next day I will not be able to comb my hair because it's so sensitive. What is hyperalgesia? Hyperalgesia is defined as any painful sensation which is exacerbated or too much to just accept the pain. What are autonomic symptoms? These symptoms include sometimes watery nose, watery eyes, sometimes ptosis, and sometimes in 45% of the migraine patients can have that. And sometimes, if you look at the research or data, patient has been diagnosed with sinus headache all their life, and then they come to our clinic for the management of the headaches. And when you go back and ask for their history, sometimes they are having some autonomic symptoms like light bothering or the lacrimation, watering of the eyes, and that help us to diagnose migraine headaches. Another characteristics of the migraine headache is there is a misconception that only the severe headache is migraine, like 4 to 72 hours, remain in the dark room. But sometimes some patient can have mild headache and they can still function. So there's a one thing which we need to think through it, that sometimes even mild headaches can be a part of migraine type. What is chronic migraine? So chronic migraine is defined as when a patient is having migraine headaches more than 15 days in a month for at least 3 months. What is medication overuse headache? Medication overuse headache is defined as if I'm having a migraine headache and I take butalbital, as soon as the butalbital effect is gone within 6 hours, I get the headache again and I have to take another butalbital. Then again after 4 to 6 hours, the level goes down of butalbital and I'm getting a medication overuse headache. So any medication can cause medication overuse headache. It's not specific for butalbital. It can be Tylenol, it can be ibuprofen, or it can be even simple pain medications. So sometimes medication overuse headaches is managed differently. Sometimes we have to take away the medication, like butalbital is one of those medications which American Academy of Neurology doesn't like it because of medication overuse headache and because of the tolerance and habituations and addiction. Also, migraine patients, because when they are working and having mild headaches and they cannot focus, they cannot concentrate, they get depressed. And because of that, they cannot sleep. Because of the headache, the quality of life goes down. They will have some anxiety, irritability, sometimes even loss of appetite. So that's the syndrome we see in migraine patients. So typically what happens is if we are having migraine headaches every day, chronic migraine 15 days, because of the headaches, I cannot sleep. And then because I cannot sleep, I'm also having tension type headache. And because of the tension type chronic migraine, then I get depression, reactive depression because of that, and then start having some combination of fibromyalgia and anxiety, depression. So it's a vicious circle. So that's the whole personality we see in migraine patients. And we have to diagnose it early and educate the patients so that we should not end up in that situation. So different syndromes can occur during this migraine headaches. The migraine is defined, it has some different phases. One is prodromal, meaning it can start from 1 or 2 days. Patient can have some mood swings, irritability. There could be an aura. Aura can last for 5 to 20 minutes or 30 minutes. And we're going to discuss about the aura afterwards. And then exact headaches, ictal headache, meaning the actual throbbing headache, boom, 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 lasting for 4 to 72 hours. And once the headache is over, then postdromal phase, which can last for even 1 day or 2 days, where a patient feels exhausted, fatigued. So 85% of the time, triggers are present. What are the triggers? Weather. Sometime when the weather changes, season changes, we who have migraine in our life, we understand somehow we will get the headache. And again, there are a lot of research is being done, but my point of view is sometime when the weather season is changing, daylight changing, season is changing, our circadian rhythm, the sleep cycle gets challenged because of the weather. The light is gone or cloudy weather, our melatonin is released, and then because of change of the circadian rhythm or sleep cycle, because of the weather changes, we get those migraine headaches. Same is the case, pathophysiology, sleep-wake cycle. When we challenge sleep-wake cycle, when we are not sleeping 7 hours, 6 hours, or 8 hours, whichever our normal habit is, and we challenge our body, then that's how we get the migraine headaches. Sometimes stress. Again, stress leads to less sleep or less quality sleep, and that goes to migraine headaches, and that goes to tension diabetics and depression. Sometimes chocolates, some people have can cause migraine headaches. Sometimes red wine. Sometimes there are some hormonal changes. Sometimes caffeine withdrawal. If I am taking too much caffeine every day, which I do, and all of a sudden, if I'm planning to stop it, in next few days, I will be getting a migraine headache, caffeine withdrawal headaches too, and that could be my trigger. So also we see in females, at the around of menses, when the estrogen is going high and the progesterone will come high and changes of the hormones, that also elicit the migraine headaches. Anytime when the patient is started on oral contraceptives, that can cause migraine headaches initiation at that time. During the pregnancy, the first few months, the frequency of the migraine headaches decreases. And then ultimately, it can change in the second or third trimester. So there are different classification of the migraine with aura, migraine without aura. Migraine with aura is around 20% of the time, if you look at the classification. And there could be different aura. So aura is defined as reversible visual, sensory, or speech-related disturbance, which can gradually come over, can last for 5 to 20 minutes. It can be positive phenomena, it can be negative phenomena. It can include visual auras, wavy lines moving across the visual fields, sometimes scotomas, we're going to discuss about it, and sometimes dark semicircular canal, some vision can come. It can extend from the center of the visual fields to the periphery. Sometimes numbness, crawling sensation, numbness can occur. Sometimes patient give us the information that I'm having some numbness, crawling sensation on the face, and it can slowly build up for 5 to 20 minutes. Then after 20 minutes, the same numbness will go on the left arm. And again, same thing, crawling sensations. Then it can go to the body, torso, or in the leg. But it will be marching sensation rather than sudden onset or face, arm, and leg numbness. And that's how we can differentiate clinically between the stroke versus migraine with aura. There will be a build-up of migraine with aura. 5 to 20 minutes, slowly build up the headaches. While in stroke, when the patient will come with the stroke, sudden onset, within seconds to minute, patient will have, I have face, arm, and leg numbness. That's how we say it's stroke until proved otherwise, okay? Patient can have sometimes prodromal symptoms, like confusion with aura can come, and then patient can build up ultimately the headaches. So this is a very good example of wavy lines. Some patient can have described as wavy electric lancinating lights or some shocks which comes and goes away, and it can impair the vision. Sometimes patient can have this type of scotoma, central scotoma. They can look at the periphery, but they cannot see the central picture. Sometimes it could be spotty scotomas. And I mean, it's very difficult for them to describe it, but still, this is the best way they can describe it, that the picture is blurry. But I think the key point is with this, it should be reversible. We are talking about 5 to 30 minutes, at most 1 hour, aura should be reversible. If it is not reversible, then it's stroke until proved otherwise. So what are the stats? So, we whenever we hear hoof beats, we should think about horses rather than zebras. So it's all about stats in evidence-based medicine. So if a patient is young female, 12 to 18, having headaches, is migraine most likely. So that's how we come up with this stats here based on the database. If you look at the database, 18% of the women will have migraine headaches, while 6% of the men will have the migraine. It is more common in Caucasian than the African American. Aura is more common in the female between age 12 and 14, while Migraine without aura is more common between age 14 and 17. Peak age of onset in the male is 5 years with aura, while 10 years without aura. The migraine can be prevalent between 25 and 55, But most commonly, when we see the pattern is usually teenage, female, teenage, male, having throbbing headaches, and lasting for 4 to 72 hours and associated with photophobia. That's a classic history. Also, migraine, usually found in the families. Sister have the migraine, mother has a migraine, and it increases the rate 1.5 to 4 times. As we discussed about the comorbidities, migraine patients can have insomnia, sleep problem, vertigo, epilepsy, stroke, coronary artery disease, PFO, patent foramen ovale, Raynaud's disease, asthma. In our practice, we have seen patients with migraine headaches, chronic migraine, which is not controlled very well, change into chronic tension diabetic, depression, and then fibromyalgia and anxiety. That's the combo we see in our clinics. Diagnosis. Again, diagnosis is very much clinical history and examination. If a young female, age 20, comes in our clinic, one-sided, throbbing headaches, lasting for the whole day, cannot focus, cannot concentrate, some crawling sensation on one side, and some light bothering, meet the criteria. On the examination, if the patient is normal, then there is no need to do any testing. It's all about history and examination. If the examination is normal and history is very much typical, slowly progressive, one-sided throbbing headache lasting for 40 to 72 hours and lights bothering, that's it. We have the diagnosis. We have to do testing, MRI or other testing, to make sure if the examination is abnormal. If the eye examination shows papillary edema, if neurologic examination shows maybe weakness, maybe numbness too much, lasting for more than 20 minutes, then it deserves to do the MRIs. In our clinic, when we see our patient, they have already seen their PCP. They are doing their best to control the migraine headaches. But by the time they are in our clinic, it is intractable migraine headaches. So in that case, in those situations, when the headache is getting worse, not responsive to normal medication, then at least you have to do neuroimaging to make sure you are not missing any other cause. So worsening of the headache, unresponsive headache is one of the indications to do the imaging. Anytime if the patient have any abnormal cranial nerves, then we need to do neuroimaging. And one thing is, if the patient says, I had a worst headache of my life, sudden onset, within seconds, then we have to rule out subarachnoid hemorrhage, and then we have to do CTs, MRIs, and spinal tap to rule out subarachnoid hemorrhage or aneurysm rupture. But the key point of the history is it should be sudden onset. Within a second we are talking about. But if the headache buildup, the classic migraine is, I know something is going on, I'm not feeling very well, and then start having boom, 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 and within 1 hour to 2 hours, I'm having this headache, cannot focus, cannot concentrate, then there is no need to do any imaging. There are different variants of the migraine headaches are there. Basilar migraine is usually consist with the posterior circulation type of symptoms. They can have nausea, vomiting, they can have vertigo, they can have numbness, they can have generalized weakness, they can have ataxia, and they can have the headaches. And sometimes it's severe enough they can pass out. It's very rare we find this basilar migraine. But again, basilar migraine is one of those things you want to make sure you're not missing any structural cause. So you have to do MRIs and all of this testing to make sure you're not missing any stroke or any other causes. Another variant is familial hemiplegic migraine. Patients having headaches, migraine headaches in the family, and they are having one-sided weakness, which can last for hours to days. And there are some special genetic testing is there to confirm it. It's very rare, but again, it should be, most of the time it is reversible. Now let's come to the some difficult concept in migraine. One concept is cortical spreading depression. So cortical spreading depression is defined as that it is the depolarization and repolarization of the wave of neuronal and glial cells, mostly starting from the occipital lobe and coming to the parietal lobe. This concept of cortical spreading depression can be best explained by aura in our migraine patients. When the patients see the wavy line, this is a cortical spreading depression from here coming here in the occipital lobe, and that's how we see the wavy line. And we can also see the scotoma in the vision, which can cause the blurry of the vision. So that's how we define as cortical spreading depression in migraine headaches. Another pathophysiology is we think there is an inflammation in the migraine headaches. And that's very much complex phenomena. So we have to understand some basics neuroanatomy here in order to understand this type of phenomena. In our brainstem, in the pons, we have trigeminal nerve. The trigeminal nerve supply ophthalmic, maxillary, and mandibular, and that all cover all the sensation. Also, the trigeminal nerve goes into the trigeminal ganglion and then goes to the pons location where trigeminal nucleus caudalis is present. All the pain fibers combined together goes into this information. Also, the C2, C3 nerve fibers from the spine comes here in the spinal cord, goes into the pons location, and they combine with the trigeminal nerve ganglion. So there is a theory the hypothesis is that somehow the patient who has migraine headaches, the pain sensation coming from ophthalmic division, maxillary division, or lower division, it goes into the trigeminal ganglion. The trigeminal ganglion goes up in the midbrain, periaqueductal area, and then it goes to the thalamus, VPM, and then it goes to the cortex and give us the sensation about the pain sensation. That trigeminal ganglion is like a central gating system. So in patients who have migraine headache, their system is not well controlled, and it is keep on firing this pain sensation. Whenever they are having migraine headaches, they are very sensitive. So that is usually out of control when they are having migraine headaches. So that's how it causes this sensation. Another concept is central and peripheral sensitization. So whenever the patient is having headache progression and patient is having throbbing headaches, then what we see is this dural vessels in this division, whether it is in the dura, either in ophthalmic, maxillary mandible division, it is causing inflammation. It is causing vasodilatation. Vasodilatation followed by throbbing headaches. The inflammation causing chemical meningitis, causing pain, and that pain sensation can be perceived as throbbing pain, hyperalgesia, or allodynia. Hyperalgesia is uncontrollable pain, and allodynia is whenever I had a migraine headache yesterday, I cannot calm because it's still sensitive. So these were the concepts which will be helpful us to understand this migraine phenomena. So it's amazing that how much scientists has learned about migraine and hypothesis are how it is generated. So in 1980s and 90s, we were thinking that migraine is vascular phenomena and vessel is dilating and causing this headache, throbbing headaches. So that's how we were focusing on the vasoconstrictor treatment. But the effect was not so great at that time. Some patients were getting better, but otherwise most of the time, we were out of that treatment. So the more research came and it showed that there is not only vascular phenomena is present, vasoconstriction or vasodilatation, there is a chemical substance are released. And the substance were released at that time. We were thinking about substance P. We were thinking about neurokinin A. And then at that time, we were also interested in CGRP. We were thinking that these chemicals were causing the whole cascade phenomena to cause the migraine headaches. So try to understand this with this diagram here, the same phenomena which we discussed before. So now we know that neurokinin and substance P may not be so much effective as compared to CGRP. Now we know when a patient is having migraine headaches, their CGRP cascade is uncontrolled, meaning the CGRP is going on the dural vessel, causing the vasodilatation and inflammation and chemical meningitis. That's why we are feeling the throbbing headaches. The CGRP receptors in the periphery of the ophthalmic, maxillary, and mandibular branch, it is causing inflammation, it is causing supersensitivity, and that's how the cascade is going on and patient is having throbbing headaches. So peripheral sensitization is there. Trigeminal vascular pathway, there is increased potential of the neuronal transmission is there. And then the CGRP system is uncontrolled. So this is another phenomena, another diagram, which is giving the same phenomena that in the periphery, the neurogenic inflammation is there due to CGRP receptors, and CGRP is causing that cascade inflammation. The trigeminal neurons is being stimulated, and then it goes to the whole perioaqueductal gray area, and that pathway goes to the thalamus, and then thalamus goes to the primary sensory cortex and causing the perception of the headaches. There is another phenomena in this diagram we are seeing in the occipital lobe, the whole cortical spreading depression coming from the occipital lobe with the increased potassium. Another diagram for the pathophysiology, this will make more sense now. So what we think is, and again, this is hypothesis. We think that patients who have migraine headaches, like me, we are super sensitive. Whether it is weather, whether it is due to sleep cycle challenge. So somehow, let's say if I'm having dental pain, so my mandibular branch will be stimulated. If I'm not able to sleep last night because of the pages, then my hypothalamic center can be challenged and it will disrupt my sleep rhythm. And then anytime if I have a head injury will cause dural inflammation or dural trauma. All these things can go back to the central generator in the pons or midbrain. And that's where all the cascade of the neurogenic inflammation or CGRP potentiated phenomena will occur, goes to the thalamus VPM, and then VPM will go to the sensory cortex, insular cortex, parietal lobe, and that's how we will perceive the pain. So it is a combination of peripheral sensitization. It is a combination of the central generator in the thalamus or pons is out of control by CGRP potentiation, and it is hypersensitivity of the dural vessel by the CGRP. So that's the theory we have at this time. Again, same phenomena. So CGRP can potentiate all this photophobia, phonophobia, nausea symptoms in the migraine patient. And this is the diagram where we can try to change or manage our migraine headaches. So in this, maybe in the cortex, if we work on it, so there will be new treatment will be coming where we will try to change the neuromodulation in the cortex. If we are able to control the CGRP receptors or CGRP itself, then it can control the migraine headaches. Same is the case with the thalamus. Thalamus can be another side where we can try to control the migraine potentiation. Hypothalamus and upper and cervical nerves. So migraine, these could be the different side for the future treatment. So if you look at the current practice, when a patient has migraine headaches, we can consider NSAIDs, we can consider analgesics, triptan. Triptan is usually 5-HT agonist, causes vasoconstriction and inhibit the neurons in the periphery and the whole complex. The results and the whole basics was, the hypothesis in the beginning was, we thought that there will be post-capillary vasodilatation and platelet aggregation causing the cascade of migraine. And that's how we came up with this the triptan medication. You know, triptan works for some patient if you take it early, within 30 minutes. But if you miss that window of 30 minutes, then it's too late because the neurogenic vasoconstriction and inflammation cascade has already started and it's too late to control it. We all know that triptan causes vasoconstriction, so it is contraindicated if a patient has coronary artery disease or stroke or uncontrolled blood pressure. Second line of medication, ergotamines, second line, sublingual, nasal, or sometimes we use it IV. When I was doing my residency, we used to admit the migraine patient for status migrainosus, and we used to give DHE protocol, IV. But before that, we used to give metoclopramide or procarbazine, Benadryl 25 milligram, and then give the DHE protocol, which was causing vasoconstriction. And again, DHE or ergotamines has a contraindication of any MI or stroke. We cannot give it because it causes vasoconstriction. Whatever the medications, we already discussed about the rebound headache phenomena with the barbiturates. And sometime in acute treatment, we can consider nerve blocks. But again, first we have to follow the protocol for well-known medications. Prophylaxis, whenever the patient having 4 headaches, more than 4 headaches per month, then that's the indication we consider prophylactic agent. And just understand the prophylaxis is this trigeminal vascular complex bundle is uncontrolled in migraine patients. It is causing firing. So we have to slow it down. The best way to slow it down is prophylactic agents. And what does the prophylactic agent does? It slows down the whole impulses. So different prophylactic agents are there. Beta blockers, propranolol is there for a long time. Some anti-epileptics are there, like Topamax, like valproic acid, Depakote has a great result. And sometimes antidepressant, amitriptyline, doxepin, nortriptyline. These are the medications are given for prophylactic agent. Calcium channel blockers have some data too. So this is the American Academy of Neurology Guideline 2012. Level A, stronger evidence, level B, and level C, so on. depending on their evidence of the studies. So first medications, level A, we sometimes try anti-epileptics. We already discussed about valproic acid and topiramate, beta blockers, and then triptans, provertiptan. Level B, we try amitriptyline or venlafaxine. Beta blockers, again, atenolol and nadolol has some level B, but most of the time standard of practice is propranolol if you look at the standard. Again, triptans have the level B evidence. Level C, sometimes lisinopril, although the blood pressure medication, but there is a data for that. Candesartan is there, and clonidine and guanfacine. Anti-epileptics, even carbamazepine has it too. But if you look at the real standard of practice, most of the neurologists or headache specialists, they first start with the Topamax if there is no contraindication. If Topamax doesn't work, then usually they go for amitriptyline or doxepin. And third medication is most likely valproic acid if there is no contraindication. There are some other complementary medications we can try. Level A is petacides, butterbur. Level B, NSAIDs are there, herbal therapies, histamines there. Again, there are herbal therapies, CoQ10, antihistamines, even ciprofloxacin has level C. So what should we do when a patient is having migraine headaches? If they are at home, we can try aspirin. We can try Tylenol. For me, Tylenol works, naproxen, ibuprofen, caffeinated products. If they cannot swallow, then that's the indication to give, IV medications. If they are in the hospital, then we can try even triptans, sumatriptan sub-Q. DHE protocol if there is no contraindication of any coronary artery disease or stroke. Phenergan, we can try NSAIDs. We can try even Depacone, 750 milligram IV for status migrainosus. Again, we want to make sure there is no contraindication for they should not be pregnant. Corticosteroids have some data too, and magnesium sulfate, 2 gram IV Q8 hours. So that's our protocol for the status migrainosus. Current treatment, if you look at it, we use, as discussed, anti-epileptic, antidepressant, blood pressure. If you look at these medications, they have some side effects. So Topamax is one of our first choice because it causes weight loss. So most of our patients like it, but sometimes it can cause kidney stones. Sometimes it can cause numbness of the fingers. Sometimes it can cause some mood swings in patients who are taking Topamax. So if a patient has a history of some mood swings, it's not a great medication. Sometimes patient has depression and then having migraine headaches, then we try amitriptyline, doxepin. Sometimes they already have blood pressure problem, then we try propranolol. These medication takes 2 to 4 months to be effective. And when it works, it's only worked 50% of the time, So the data is very, very small data for these patients. And if you look at ultimately these patients, when they are taking these medications, they stop medication after 1 year, 83% of the time, because of the side effects of these medications, whether it is Topamax, whether it is amitriptyline, doxepin, whether it is propranolol, because of some side effects. So because of that, the research continued, and the CGRP, the protein which was initiating the whole cascade of the migraine headaches, the new medication came, the receptor blockers and the protein itself ligand. And we're going to show you all that information. And if you look at the data, it is decreasing. The erunomab, Emovic, it decreases 6 to 7 days. And if you look at in 1 year, 79 days without headache when you are taking Emovic as compared to no treatment. Same is the case with the galcanezumab and eptinezumab reduce monthly migraine by 75% of the time in 1/3 of the patients. So this was published in 2017, and then ultimately we started using it with the CGRP antagonist. So CGRP antagonist can be divided into ligand binding versus receptor binding. So CGRP protein is usually involved in the pathogenesis of migraine headaches. It causes vasodilatation. If it is in the brain, in the dural vessels, it will cause vasodilatation. It is also found in the heart. It can also found in the kidneys. CGRP protein will cause vasodilatation in the brain, in the heart, in the kidneys. And this is a chemical of the composition of the CGRP protein. So because of this history, the scientists start working on how to control the CGRP before starting the cascade. So they came up with the ligand binding antibodies and receptor binding antibodies. So with that information, the pain level of migraine was well controlled, and it controlled the headaches in 50% of the time, and the result was very good within 1 month. Same phenomena, same thing. They're controlling the vasodilatation induced by the CGRP. Just remember that concept there. CGRP is causing the migraine. We are controlling the CGRP proteins and receptors. So this is a good example that when we are giving CGRP antibodies or receptor antibodies, we are trying to control the CGRP generated neurogenic inflammation caused by mast cell, or vessel dilatation in the dural vessel, or in the thalamus, the whole potentiation by CGRP. So there are two kinds of CGRP. One is anti-CGRP monoclonal antibodies, which are ligand, and another is anti-CGRP receptor monoclonal antibody. By the name, it means the receptor will be controlled and ligand will be controlled. So just remember, scientists were doing the research from 1982, and we discovered the treatment in 2018. So CGRP will be working on the dural vessels. It will be working on the brain itself to decrease the CGRP-related potentiation. So the receptor which block it, we call it as Gepants, while antibodies are called antibodies. It will be working on the thalamus. It will be working on periaqueductal gray area, and it will be working on trigeminal ganglion. So monoclonal antibodies, Aimovig was approved in 2018. So Aimovig erinumab is the one antibody which act on receptors. Just remember that. There's a one exception here. While all the other IV monoclonal antibodies are ligand bound. So they catch the CGRP before it starts the cascade. So Aimovig erinumab, Ajovy is a fremanezumab, Emgality is a galcanezumab, and Vyepti is a eptinezumab. In practice, we are using more Aimovig because of the receptor. Ajovy we use it, and Emgality we use it. We have not used Vyepti yet, and it's very much related mainly related with the insurance companies. The patient has some specific insurance. One insurance will pick up the Aimovig, another insurance will pick up the Ajovy. And this monoclonal antibodies will either the Aimovig or erinumab will be taking care of the CGRP receptors, while all others will be taking care of the CGRP protein. So CGRP receptor antagonist, which will be working on the main receptor so that the whole cascade will be dislodged and there will not be any more potentiation or neurogenic stimulation. And for that, Gepants is Ubrogepant or Ubrelvy. Another one is Rimegepant, Nurtec, and the third one is Atogepant, Quilepta. And remember, this is mainly acting on the receptors. So these are receptor antagonists, Gepants. So same information in the diagram that this anti-CGRP antibodies include fremanezumab, galcanezumab, eptinezumab. While CGRP receptor antagonist will be Rimegepant, Atogepant, and Rimegepant. So again, CGRP antibodies or receptors, blockers, they're working on blocking the neurogenic inflammation. So they are taking away the CGRP proteins, while that neurogenic inflammation, which will be causing the chemical meningitis and causing the headache, that's how it is blocked. Same thing, they will be also blocking the cascade of vasodilatation by decreasing the artery dilatation by CGRP antagonist and CGRP receptor antagonist, and also they will be inhibiting the pain transmission. So these are the three mechanisms. Mainly, they are decreasing the whole effect of CGRP, the CGRP inhibitors. So this is the diagrammatic expression of why we were treating the patient with triptans, because we thought that vasoconstriction will help. Effect was modest, but not much. And the receptors were different. We were focusing on 5-HT, 1D, and 1B receptors. So in conclusion, now we have different kind of treatment for migraine. The main thing is we can help these patients to control the headache. It can be, first we have to try different standard of care is usually try Topamax. If Topamax doesn't work, then we try second medication, usually amitriptyline or doxepin. If that doesn't work, then usually we try CGRP receptor antibodies. This is very much a standard of practice. Usually insurance company only approve it when we have tried these two medications. These are different things we can try. The good thing is that with the CGRP antibodies and receptor antibodies, we don't have to worry about any vasoconstriction. So if a patient has a stroke or even heart attack, we don't have to worry about it, and we can give them these medication to them. There is no age contraindication. Patient can, at age 60, 70, we can use these CGRP medications. There's another class is coming, which is ditans, which act on 5-HT1F receptors. This is working before the CGRP is released. This ditans, lasmiditan, is usually we have to recommend that patient should not be driving after taking this medication, because patient can have sleep problems. They can sleep for at least 8 hours. So this is the summary. Adalimumab is the Amovic, but it works on the receptors. Galcanezumab is Emgality. Fremanezumab is Ajovy. Eptinezumab is Vyepti. Rimegepant is usually worked on the receptors, so it can be given for abortive treatment. And Ubrogepant is Ubrelvy. Again, it's work on the receptors, so it can be given as an abortive treatment. So Rimegepant, Ubrogepant, and Atogepant is missing, can be given for migraine attack acutely, as for the status migrainosus. While this eptinezumab, fremanezumab, galcanezumab, and adalimumab can be given as a prophylactic agent as a monthly treatment. So there was a data for Ubrelvy. Again, if you look at the data, there was a quite effect that decreased pain sensation, and after 2 hours it was 60% release. For the pain control was also there for 24 hours. For Rimegepant, the data also suggests that patient was headache-free, decreased headache for 4.14 headaches as compared to placebo, and greater than 50% responder rate was 62% as compared to placebo. Rimegepant, which is also known as Nurtec, showed the rate of freedom of headache in 19% as compared to 12% with placebo, and again it was observed. It was symptom-free in 37.6%. Rate of pain relief was statistically better than placebo in 1 hour, 37% versus 31%. And Ditans, we discussed about Rimegepant. Again, this is very new medication. I have not used it yet, but just be very careful. This is patient should not be driving after that. It is supposed to cause some sedation, dizziness, somnolence. So that's the one thing we have to worry about, and this will be class 5 drug. So these are the references. Now let's go to question 1. When can we consider CGRPI? So just remember, there can be one answer could be correct or could be more than one answer. So when can we consider CGRP? Age less than 18, pregnancy, failure of 2 prophylactic medication, or first agent. It can be one answer or more than one answer. We are ready for your answer. Is it working? Yeah, now it's working.
It's working.
Okay. So it will be, so answer is failure of 2 prophylactic agent, then we can consider the CGRP. So when should we consider triptans? Status migrainosus, age greater than 55, history of stroke and MI, new history of migraine headaches, or hemiplegic migraine. When shouldn't we consider triptans? All right, so we shouldn't consider triptans when a patient is having age greater than 55, any history of stroke or MI, or any hemiplegic migraine. And the reason is, if you give the medication triptan in hemiplegic migraine, then there is a risk for vasoconstriction and hypothetical risk of having stroke. What can be considered for status migrainosus? It can be magnesium sulfate 2 gram IV, promethazine 10/25 IV, Depacone 750 milligram IV, Benadryl 25 milligram IV, Solimedrol 125 milligram IV. It can be one answer could be correct or more than one answer. So when a patient is having status migrainosus, magnesium sulfate 2 gram IV can be considered, promethazine 10 or 25 milligram IV can be considered, Depacone 750 milligram IV PRN can be considered, Benadryl 25 milligram IV can be considered, and Solimedrol 25 milligram IV can be considered during status migrainosus. All right. So this is end of the lecture.
Ask one more time if they have any questions.
If you guys have any questions, you can write it in on the chat and we will be happy to answer. All right. Thank you very much. Thanks a lot.